In the 1980s, the world found out about HIV and AIDS. Better drugs means it's no longer very often a death sentence, but there are still hundreds of thousands living with the virus. Well, Britain has set a goal to be the first country to have no new cases of HIV by 2030. How has this happened? Very good to have your company. I'm David Foster. You're watching Roundtable. It was an everyday conversation a couple of generations ago, no longer. While HIV can lead to AIDS, where your immune system effectively shuts down, huge advances have been made.
Almost 40 years ago, AIDS was a death sentence. The HIV virus was first identified in the 1980s, and the number of AIDS-related deaths rose to reach a peak in 2004 and 5, when 2 million died each year. The development of anti-HIV drugs have helped many to live with the virus, but millions are still being infected. The World Health Organization revealed 940,000 had died in 2017 from HIV-related illnesses, and 39.6 million lived with HIV and AIDS. While AIDS has disappeared from the headlines, Britain has set a bold goal to be one of the first countries to reach the UN zero infections target by 2030. It's a start, but what will it take for the world to be AIDS-free?
Okay, let's get the ball rolling. Joining us from Bristol, I'm pleased to say we have Amanda Ely, manager of Children's HIV Association, known as CHIVA. With me at the round table, Sarah Fidler, professor of HIV medicine at Imperial College London, Garry, Brough, deputy chief exec at Positively UK, himself 30+ years HIV positive, and Jenny Vaughan, advocacy advisor at STOPAIDS. Great to have you all here. And it's a great headline. We'll get into it in some detail in just a moment. Amanda, nice to see you too. But you were telling me before the programme, nobody uses the word AIDS anymore.
So AIDS specifically is what we used to see before we had antiretroviral medicines. Those are the medicines that treat people living with HIV, and they prevent any virus replicating, so there's no virus in the blood, and then the immune system recovers. So we don't see people who know their HIV status who are on treatment progress to AIDS and death anymore. So I never talk to my patients about having AIDS. We talk to them about living well with HIV. How
did Britain manage to get to the point where it could well be the first country, this is for anybody, possibly the first country to have no new HIV infections? Who wants to start that one off? Go on, go on.
A huge part of it is education and information and awareness raising. But also, I mean, I work across a number of different diseases, and people always say to me, like, the strength of the HIV movement is like something that we've never seen before, and something that we need in TB, something that we need in non-communicable diseases that are becoming more and more the things that are going to kill us, the cancers, the diabetes, etc. The HIV movement, from the get-go, it became political. From the get-go, it was about people's rights and people being able to access healthcare. And the fact that it has, well, now today it is continuing to affect those that maybe are more marginalised in society, I think shows why it's had this political nature. But I think, you know, taking it on as a political issue, driving that education forward, and kind of really coming together as a movement has been really integral globally, and I'm sure in the UK context.
Garry, you were diagnosed, what, 30+ years ago? What did they tell you then?
They told me I had about 5 years to live. I was 23 at the time, and so I wasn't expected to see 30. But within 5 years, there was effective treatment available. So I was offered AZT when I was first diagnosed. There was a trial to looking at the one drug that they had. But what I saw that I didn't like, so I didn't try the drug, and I waited until combination therapy came up in '96 and then started in '97. And so I've been on treatment since then with an undetectable viral load. But I was very ill through the 90s.
Let's be clear about this. Some terminology I'm not au fait with, but undetectable viral load means you cannot pass it on.
Yeah, so as Sarah said, once you take the medication and it prevents HIV from replicating, the blood test they do to check that is the viral load, the amount of virus in a blood sample. And when it's undetectable, when you can't find the virus, obviously it can't do any damage, but it also then can't be passed on. And it's something that was kind of, there was an awareness of it, but it wasn't until the late 2000s that anybody really spoke about it publicly. And in 2008, the Swiss AIDS Federation made a statement which said that people who were undetectable and stable on treatment couldn't pass on the virus. And there was a fair amount of outrage from the international community, because there was a big fear that, you know, people with HIV would then stop using condoms, and what if they stopped taking treatment? And so all those anxieties about people's behaviours, which lie at the heart of some of the anxieties and fears around HIV. But what we've seen, certainly in the last 10 years, is that actually in countries where there's good access to treatment and people are managed and stable and undetectable, as a result of that, as well as all the other combination prevention methods, so condom use, PrEP now as well, early testing, that means we're now seeing a drop in diagnosis. And so the UK has done better than anywhere else, and London is certainly further ahead than almost any other city in the world.
Okay, Amanda, we'll talk about children because it's a very important part of this in just a moment. But in general terms, you must be delighted, because you deal with parents as well who are HIV positive. You must be delighted at how far this country has come.
Absolutely, absolutely. I mean, and very much linked to children still is the huge successes in the reduction and almost complete eradication of mother-to-child transmission of HIV in this country.
Let me ask you, when it came to specialising in this and looking at it, did you imagine that such progress could possibly be made so rapidly?
No, it's been an extraordinary experience for me personally, in that I qualified as a doctor at the end of the 1980s, and in my very first medical job as a kind of brand new doctor, I was looking after people with HIV at the time who were the same age as me, so in my early 20s, who were dying of a completely untreatable condition. And it was extraordinary that suddenly within, literally as Garry says, within about 5 years, there was this massive change in prognosis, and now the treatment is far less onerous than it was then. I mean, treatment was available in the mid-1990s, but it was really difficult, very complicated regimens, lots and lots of tablets with lots of awful side effects.
And now?
And now most people are on 1 or 2 tablets once a day, and they can see a normal life expectancy. So, I mean, absolutely dramatic change.
We'll talk about the rest of the world in a little while, if we may, but medically, if you have HIV, okay, these drugs prevent the virus from replicating, it's non-transmittable, etc. Let's say, very unfortunately, you do develop the acquired immune deficiency syndrome, AIDS. Is there any way of recovering from that?
Oh yes, absolutely. So most people who don't, the most people we see who present to us in hospitals in the UK now who are sick, usually it's because they didn't know they had HIV, so they had never tested, and that's one of the most important parts of the whole campaign, is without knowing your HIV status, you can't get onto treatment because obviously you're not aware. And again, for people who are negative, it's about helping them to remain negative. But when we see people coming to the hospital sick with an AIDS-defining illness, so that's when their immune system is not working, we can treat whatever that condition is they have presented to us with. So usually these are quite severe and very unusual infections, but we have learned over the years how to treat most of them. And then when people start the antiretroviral medicines, everything reverses. So their immune system recovers, and then they are no longer in that significant state, which is why we don't talk about patients having AIDS.
So would you say they don't have AIDS at that point, because you've sort of sorted out their immune deficiency?
Well, technically, if you come to a hospital sick with an infection that you wouldn't normally catch because your immune system isn't working, that is defined as an AIDS illness. But once your immune system recovers, you no longer have AIDS.
Extraordinary. So many of those people that you would have seen first of all, when you qualified as a doctor, would have had no chance of survival.
No.
And now, 98, 95%?
Yeah, if not more. I mean, the earlier people know their HIV status and they start treatment, the less the risk is that they will ever get sick with an AIDS-related illness.
And did we get to this point, do you think, because it was so talked about? In many ways, it was vilified. I had a member of my family was HIV positive. He lost his life to AIDS, but it wasn't something that a lot of people wanted to dwell on at that particular point. But it was something that was in the papers the whole time. Is that why?
I think, you know, there has been in this country a huge amount, like I said at the beginning, education, talking about it, information sharing, and we have universal health coverage. We have an NHS. You can go to the doctor, you can have a free test, you can have counselling, you can be put onto treatment, you will never pay for that. You know, you can, and you know, you can access the drugs that you need. If the first line, so if what the doctor gives you to begin with doesn't work, or you're reacting badly to it, you can have something else. And again and again and again, we have this kind of, you know, we have the support structure in place because we have this brilliant health system here. But I don't want to, you know, bring us all into a dark cloud. But globally, the situation is very different. So in 2000, then we had just 2 million people on treatment globally. Now we have 22 million, so that's a huge increase. But we still have 17 million people that aren't on treatment. And if you think about it, that's almost half. So that's pretty staggering. And I think, you know, there are multiple reasons why we haven't got to that end stage of getting everybody onto treatment. A lot of it's to do with testing. A lot of it is to do with stigma and discrimination. A lot of it is to do with the fact, you know, very hard facts that in some countries in the world, you know, there's criminalisation around HIV, there's criminalisation around homosexuality. The two things together, you're unlikely to go and see your doctor because you don't feel safe. Even if you had, you know, a kind of a free point of view system, you still wouldn't turn up. You'd be scared for your life and your family's life.
Very difficult to put a price on a human life, of course. We all know that. But is this very expensive to have got to this particular point and to supply the drugs? Do you know anything about that? Well,
today it's the medication that I'm on, because it's an older medication. It's very, very cheap because it's a generic. And so we've now had HIV drugs for long enough that they've come off patent. And so while there are new drugs being developed all the time, which are useful for people who may have resistance or may not tolerate some of the drugs, you know, the UK now are moving towards just generic prescribing for HIV medication. So what would it cost £12,000–15,000 20 years ago when I started, now costs less than £1,000 a year. And so in terms of keeping me alive for that rate, in terms of the cost effectiveness, it's a phenomenal achievement for a lifetime of drugs for just under £1,000 a year.
Well, you mentioned the stigma that there was back in the 80s and in the 90s as well. How were you treated by society in general at that point?
I was treated well, but I chose to speak about HIV, and I was at university. I had an accepting family and an understanding friends, and so my experience was not the usual one. In terms of the support work I've done over the years and the people that I see, for most people, the fear of disclosure, of telling somebody their HIV status, is such that they don't tell people, or when they do, because of the fear and anxiety, often the reaction is bad, or because the public information campaign in the late 80s was incredibly effective. You know, that whole "Don't die of ignorance," the tombstones and everything. But there's a legacy from that today, which is that fear and anxiety around HIV, and people still think about AIDS. Whereas, as Sarah already mentioned, we don't talk about AIDS, but people think about HIV. They think AIDS, they think death, they think infection, and all of those fears combine to make it a very potent, difficult subject to address, because it's also about sex.
Also, there was this idea put about by, I think wrongly, by a lot of some people, that it was your own fault.
Yeah. Well, it's the fact that for most people it's sexually transmitted, that then comes with its own judgment about sex. And so that, you know, I was in a conversation last week where, you know, there was this discussion about people asking, how did you get it? And I said, you know, when people ask a pregnant woman, oh, how did you get it? That's when we'll be at the same stage of not worrying about this. But, you know,
people start asking pregnant women, we've got a problem with the education in this country.
Nobody has a judgment about a woman being pregnant, but having an infection in relation to sex is a whole different issue, and it's foolish.
Amanda, I watched a video on your website in which 3 actors played 3 young people, each talking about how difficult it was for them to accept that they'd got something that they hadn't brought upon themselves, that had been passed down through their birth. I believe I'm right in saying that in each case. It's doubly difficult for somebody who has no idea that they've got it to be told they've got it through no fault of their own, no actions of their own.
Yeah, I mean, I think really to echo Gary's point there, I think this whole issue of, you know, where did you get it? We really need to kind of move away from that. But definitely for the young people that we work with and we support, you know, it's something that they find very difficult. People expect them to have an explanation of why they have HIV if they have in fact chosen to tell anybody, because I think what's a typical experience for young people growing up with HIV is that they tend not to share it very widely at all, if beyond their families and their professionals that support them. And I'm really pleased to hear that you've watched the film, because I think the film kind of, it was the words and stories that young people themselves shared that was written into that piece, and it really kind of vividly expresses just how challenging it can be to grow up with a disease which does remain highly stigmatized. I mean, we talk about the stigma that existed in the 1980s and in the early 90s, but I would argue that it's still very prevalent today, and that the education that happened perhaps then, when there was a lot of alarm and fear about HIV, has really been largely missing in the past kind of 15 or so years. You ask children today what they learn about HIV in school, and it's barely anything.
There's a danger in that, though, isn't there, as well, that we sort of push it to one side?
Yeah, absolutely. I mean, people are still very surprised to learn that there are children and young people that live with HIV in the UK. People assume this isn't something that's happening here. They assume that children live with HIV in other countries, and people are often surprised to hear about our work when we say that there are children growing up with HIV here. They don't think that that's happening here, and I think that's a reflection of the fact that we don't have, very much HIV education that occurs both in schools, but also, more publicly. When was the last HIV awareness campaign that was, a kind of national campaign in this country before this Evening Standard campaign? I think that we can, we have to be very cautious at not thinking that it's over now, because I would argue that there's still a lot of work to do in terms of raising that HIV awareness and understanding,
you want to say
particularly for young people.
Yeah, no, I think that the other thing one has to think about when you talk about young people, and I think it's very pertinent to the African setting in particular, is that if a young person who's growing up with HIV discloses their status, or they share their status with a partner or a friend, they are automatically also saying, by the way, my mother has HIV, because that's how it's transmitted. And I think that, the stigma that's associated with sharing your status with somebody is still extremely challenging. I don't know if you think this, Garry, but for young people in particular, because there is a terrible judgment, but we don't make the same judgment about obesity and diabetes, about drinking and liver disease. Somehow there is a particular thing, and I think, as you mentioned, it's around sex. We're still not very good and open about being able to discuss the fact that HIV is historically in many people, but not everybody, linked with sex.
In a sense, you can't equate it with liver disease, because that is something you get perhaps by picking up a bottle yourself and drinking it. But you could perhaps more logically acquaint it with something like TB, which can be transmitted through air particles, because it is transmitted from one person to another. And is that part of the stigma?
I think when I was talking about alcohol and liver disease, it's more about behaviour. So it's more about a judgment going, you brought this upon yourself. You chose to have unprotected sex. You've got HIV, your choice.
But equally, those things you mentioned, like diabetes, etc., they aren't transmitted from one person to another, whereas the HIV virus is, as is tuberculosis, etc., I don't think it's going to be rather difficult to get around that one, isn't it?
I wonder, if I could just talk a little about to the complacency point that Amanda was making, because that's something that we really focus on at STOPAIDS, and in the children's setting, it's really interesting to hear about it spoken about in the UK context. So globally, we've been working on a campaign recently bringing to light the fact that only 52% of children living with HIV globally have access to treatment. So that goes back to that point that I was saying before about the 22 million, but where are the 17 million, and how many of those are children? And why don't they have access to treatment? Well, it's because the treatments don't exist, Where we do have treatment, they're often suboptimal regimens. That means they can make them unwell or sick, and they're less likely to be taking them. It's also
is that rather like our drugs were some time ago?
Yeah, I guess it's a similar thing, but also it's obviously much more, I'm not a scientist or a doctor, so do correct me if I'm wrong, Sarah, but it's obviously much more difficult to give a very young infant medicine than it is to give an adult, and we need specific formulations and different drugs. The World Health Organization came out a couple of years ago, or even last year, and said there's this new amazing wonder drug called dolutegravir, and it should be first-line treatment for everybody of all ages living with HIV. There's no version of that for children, very young babies, under about, I think it's under about...
Working on that in your community?
So I'm not a paediatrician, so I don't
No,
work
but
with children,
you read a lot of stuff as well.
Yeah, I mean, I think the point is that it's about testing and linking those children into care, and clearly there's a physical, getting a baby to swallow a tablet is not possible, so they have to make the drugs in the right formulation. So it's got to be a liquid that you use in a syringe for a tiny baby. And
they used to put it on a sugar cube for us when it was polio.
Yeah, we're not allowed to do that
rots your teeth.
Yeah. Yeah, but I think, I mean, going back to the wider point about complacency that Amanda was making, this is like what is like first and foremost in so much of our work. HIV prioritisation is half of what we do. We're trying to remind the UK government on a daily basis that globally this isn't over.
But they've done rather well, don't you think? I mean, our government gets knocked a lot, whether it be of a Labour hue or a Tory hue. Tory at the moment, but you've got to congratulate the government for getting to this 90-90-90 ahead of anybody else. Gary?
So, yes, with some reservations. I mean, we've seen prevention funding decimated over the last 15, 20 years since medication became available. And so the prevention messages have got less and less. But because treatment has got more and more accessible, then that has partly done the job. So there have been targeted campaigns for gay men in African communities who are seen as to be the most at risk. But what we're now seeing then is those people that the messages are not getting out to. And so if we're going to get to zero, which is what the government is now talking about, it's about those people that are not, the messages are not getting through to them. They keep talking about hard to reach. But the fact of it is that just the messaging isn't getting through in an effective way to communities and individuals that don't consider
well, that leads me to this. I've read this press release from the Terence Higgins Trust, which has been one of the prime movers in raising awareness, etc., with regards to HIV. And it says the Department for Health and Social Care, a government department, has confirmed that an expert group will now be established to develop an action plan over the course of this year. Question to each one of you, what does that action plan need to involve?
People living with HIV, obviously, I'll say that. It needs to involve the medical community. It needs to involve commissioners who commission those services around prevention and treatment locally and nationally. It needs to involve the voluntary sector who work alongside the clinical teams to provide that holistic part of the care that isn't just medical, because HIV, once treated, is very manageable, but actually the living with the virus and dealing with some of the psychological issues, and then all of the other things that link into that, the sort of the whole person care that's needed, requires a combination approach. So you need to have medical and psychosocial support around all those areas. So it needs a joined up approach.
And do we not have that at the moment?
I think that's actually one of the major problems in the NHS and social care, full stop, is that if you look at where our gaps are, so being very positive, we've done a fantastic job. I don't want to take that away from anybody. But the gaps, so those people who are not aware of whether they're living with HIV or not and not on treatment are at risk themselves of obviously getting sick, but also potentially unwittingly transmitting it to partners. And those gaps are often a more vulnerable population. So they're people who maybe have mental health problems, who may be immigrants, who may have other difficulties in their lives, which mean that they are not engaging with the services we have. And linking together social care with provision of NHS treatment or prevention is partly, from my experience of working in a hospital at the moment, where the gap is. And this government decision, if they really want to make a difference, is going to be linking up social care, mental health services with NHS.
STOPAIDS, will we be able to do that?
We think
completely?
That it's possible. We have the tools, we have the know-how, but we are way off track, and that is it's still political. It's still to do with political leadership. It's still to do with financing, and it's still to do with priority setting. This year we have the replenishment of the Global Fund to End AIDS, TB and Malaria, a massive multilateral organisation that's working all over the world to get prevention, treatment, care and services to people that need it. We need the UK government to continue to step up and be a leader in that space.
But in all honesty, in countries that don't have access to the funding and the research, where there are major health issues, let's say with regard to cholera outbreaks, with regards to malaria, where healthcare is way down on what we see here.
Yeah.
This is not going to be a priority?
I think it has to be.
Should it be? Well, what?
It has to be, because, you know, all these things are interlinked. It's about strengthening health systems, and that's what these multilateral mechanisms are beginning to wake up to and trying to do more and more. It's about not just making sure that people have got HIV treatment, care and support and services in their community, but that also the rest of the health system is fit for purpose. The rest of the health system can care for them as a holistic. So
one thing follows the other, perhaps?
Absolutely, I think it does. And I think, you know, we're always learning about what works and how to do it better. You know, the UK government has taken the decision to downgrade its kind of more bilateral approach. So just going into countries, one-to-one relationship, giving money for a particular project and then seeing what happens. And instead it's channeling its money through instruments like the Global Fund. There are other multilaterals I could talk about. But I think it's about understanding then, okay, well, if we're going to pool our collective power, our collective know-how, we're going to work with other governments, both the donor governments and the recipient governments. It's about figuring out how we do that.
I have to stop you at that point because we've reached the end of our time. Thank you ever so much for coming on. Amanda, sorry I didn't give you a chance to have the final word on that, but we do thank you for being part of the programme. Garry, best of luck. How many years now?
30 years.
30 years, fantastic. 30 years we've been talking about this. We've tried to do a little bit in 30 minutes. It really isn't sufficient, but we hope it contributes to the debate. Thank you for joining us, and thank you for watching. See you next time. Bye-bye.